I'm John Cheville, a pathologist here at the Mayo Clinic.
I am George Vasmatzis, a bioinformatician here at the clinic. So once we've set up the team, and assuming that we have the right samples that we can interrogate to look for biomarkers, we use cutting-edge technologies like next-generation sequencing and microarrays to comprehensively look at the tissues for molecules that they change between disease state and normal state. That's where we fish for the biomarkers. That's where we find plenty of alterations that they could be potential biomarkers. But they are not biomarkers until the clinical utility has been proven. And we do that in a second step, where we take some of the most promising changes, and we see how in an independent study they can really predict correctly the clinical dilemma. When that is happening, we focus on the one or two or three molecules, and we develop tests around those molecules. So we have several projects that they have started 2 or 3 years ago. What we decided to do, the co-directors, we decided to take as much money as we can capture from different sources, clinic, NIH, or benefactor funds, and then spread them in multiple different disease areas and in all 3 sites at Mayo Clinic.
The challenges are, you go to the medical literature and every month you find new biomarkers that are being published, but most of those won't make it into clinical practice. And the real hurdle that we have to overcome is, do these biomarkers add value to our current care? And a lot of these biomarkers that are coming out don't. So in our studies, we have additional steps after discovery of the genetic change that show us that this really adds value to what currently we do in the clinic. So in terms of diagnosis, it improves our diagnostic ability. In terms of prognosis, it better determines how patients will do with their disease, or identifying new targets that haven't been identified before. So really, does it add value beyond what we currently have available for our clinicians?